Hello mate, SSRIs Nation. Today's all about ketamines. I've got a very special, unique medical doctor, general practitioner on the show. It's a privilege to have him. Welcome, Dr. Sean Thornley.
Thanks very much for having me, Steve. I appreciate the time.
Brilliant. First thing I want you to do is, what is a ketamine?
So ketamine is a general anesthesia. It came around in the 60s and 70s as an alternative to phencyclidine. So it was originally patented as an anesthesia. The phencyclidine had some pretty severe, horrendous side effects that were intolerable and found to have no real use in practice. So the ketamine was a sort of step upwards in terms of creating an anesthesia with less potential for side effects, and it was fantastic in places like the wars, and they were able to use it on the battlefield, and it had a very neutral, stable cardiovascular profile. It wasn't dropping blood pressures like the other anesthetics were doing. So it originally gained a lot of traction as a general anesthetic, and still to this day on the World Health Organization's list of essential medications for any healthcare system. So originally all the evidence for anesthesia is still used today as a great anesthetic, and in the 2000s onwards started gaining traction for the treatment of mental health, and that's where we find a lot of its adjunct uses today for the treatment of mental health disorders.
Brilliant. Give us two amazing stories, possibly a male and a female, that people can grab hold of.
Sure. Well, I mean, look, obviously ketamine for treatment-resistant depression will come, and we'll speak about that now, but there are some other indications for ketamine use, a little bit more off-label, and the one case is a 55-year-old lady with a terrible history of alcohol dependence and addiction, and has really struggled with traditional treatments to get off of her alcohol. And so she was referred to me by a psychiatrist for ketamine therapy. We did 6 infusions for her. And when she went under the infusions, she used the intention of a Count Pushkin bottle. And her goal was to destroy this Count Pushkin bottle one way or another. And it turned out that she dissolved it in a stream of lava when she was under the infusion. And I received a message from her a couple of days ago saying she's 6 months and 2 days clean of alcohol. She's just started, she's actually just starting a new job now in April, and very grateful for the process. So that was a great, rewarding story from an alcohol dependence point of view. And the second is a 45-year-old guy with a terrible neurological condition, a family friend of mine who has a condition called spinocerebellar atrophy, which attacks the cerebellum, which controls balance, coordination, gait. And his speech was severely affected by this. He's tried all forms of Western medicine treatments. He's been overseas for alternative therapies, including spinal injections and stem cell treatments, and nothing really worked for him. And we've done a series of ketamine infusions for him, and he's noticed a massive improvement in his quality of speech, and that's confirmed by his partner as well. So obviously this is with the permission of his neurologist, and so yeah, he comes to me for a series of ketamine infusions, and he regularly reports positive benefits from them.
Sure, sounds amazing. I've had patients over the years, having been in practice 24 years, and they just absolutely swear by ketamine for post-traumatic stress disorder, anxiety, OCD, obviously the addiction story you've mentioned, but it sounds too good to be true because it doesn't seem that mainstream medicine has taken it on. Why is that?
Look, I think the problem is that patients are so fixated on a quick fix. They're not prepared to do the hard work, and I think that's the problem, is that they see the silver bullet, ketamine or psychedelics or whatever it is in the mainstream media that's come out now, and they don't realize that they actually need to go back, and they need to start from the basics, and they need to look at transgenerational trauma, they need to look at childhood traumas, they need to look at functional and integrative approaches to improving their mental health problems, and that they shouldn't be using things like ketamine and psychedelics as a silver bullet to cure their problems, whether that's depression, post-traumatic stress disorder, anxiety, OCD, eating disorders, etc. The ongoing work needs to continue with your general practitioner, with your psychotherapist, with your functional medicine doctor. You need to look at improving diets, etc. And it's not just 6 infusions and there you are treated and cured. This is a tool in a toolkit to help improve your system. Very often a patient's tried everything. They considered treatment-resistant depression. They've had 2 or 3 types of antidepressants used. They've used antipsychotics, for example. They've done psychotherapy. They've improved all of their metabolic parameters. They've improved their diet, and they're still treatment-resistant depression and or possibly even suicidal. And so something like ketamine just allows them to pick themselves out of the hole so that they can actually engage and do the hard work again. And so that's where the best benefit comes from.
So from what I know, and I've done a lot of podcasts on anxiety and trauma, that trauma can get locked in a cognitive sort of area, and it's very important to do cognitive behavioral therapies and a lot of these modalities that look at the psyche, but then trauma can get locked on a cellular level. How important do you think it is to make sure that we get unshackling or unlocking of that trauma at a cellular level that can cause significant downstream effects?
Look, I 100% agree with that. The analogy that I use is that your mind is like a ski slope with a beautiful dusting of snow on it. And you take your toboggan down and you carve a pathway down to the bottom of the slope. And the next day you go, no matter where you put your toboggan, if you go on down the slope, you end up in that same rut and that same pathway. And very often the mind is like a ruminating pathway. You keep getting stuck in those same thought processes. And that's why things like cognitive behavioral therapy are beneficial, to try and train your mind to grow new pathways in the brain on a cellular level and on a structural level as well, with the neurons and the synapses, etc. So things like ketamine offer you a solution in that they give you a new dusting of snow on the slope, and so they allow you to forge new pathways. So if you go into these processes with the correct intentions, under the guidance of the correct therapists and psychiatrists, for example, you can create new pathways between old brain cells, and you can create new brain cell formation, so synaptogenesis and neurogenesis in the brain. So really you can teach an old dog new tricks here.
Sure, sounds incredible. But what about somatic anxiety that people feel in the body? Do ketamines and psychedelics or any of these sort of treatments help with somatic anxiety? Some people actually refer to it as false anxiety. It's not true anxiety. They call it techxiety or hangxiety. When you're hungry, you can get anxious. You know, when you've had too much tech, you can get anxious. But does it help with that somatic anxiety?
Yeah, 100%. I think, you know, there's a sympathetic and a parasympathetic nervous system, the fight and flight and the rest and digest part of the body, and very often the physical manifestations of an overactive sympathetic nervous system are physical manifestations such as gut problems. You know, the large majority of your serotonin, for example, is produced in your gut, only a small percentage produced in the brain. So the gut-brain axis, I think, is really important as well. And so very often people manifest their anxiety in their stomach, they manifest their anxiety in their chests, they have crushing sensations, panic attack feelings in their chest where they think they're having a heart attack, for example. The nice thing about ketamine is that it seems to unravel and unwind that sympathetic parasympathetic stress response and create a little bit more of a level playing field for people. But again, if they go back and they put their toboggan down on the ski slope and they keep doing what they kept doing to get into the same situation, they're going to end up back in trouble again. And that's why the other forms of treatment, such as cognitive behavioral therapy, functional medicine, integrative medicine, psychiatry, psychology, the traditional approaches definitely play a role here.
Brilliant. So tell us about the process. Someone's thinking, they're listening now, that have chronic anxiety. I mean, the figures in South Africa are crazy. SADAC, the South African Depression and Anxiety Group, has said, you know, employees aged 31 to 59, there's 59% of them that have a mental health condition. It's crazy.
And that's only what's been diagnosed. I think what we're actually seeing in real life are figures that are substantially higher than that. A large majority of people aren't coming out of the closets to say that they have a mental health condition, or there's a stigma behind coming out and say, I mean, when I ask people if they have a family history of mental disease, they say, I'm quite sure my dad has a problem, but their generation never spoke about it. Well, there's still a huge subset of people in South Africa that don't talk about mental health problems. I think there's been a massive spike since the COVID pandemic as well. I think the rates of anxiety and depression from COVID and from the fear that was created by COVID is massive. And so we're seeing a lot more people come through to places like ours via their psychologists, via their psychiatrists, referral through friends, for example, because of a mental health condition.
Cool. So what is the process? Do people need to do sort of pre-ketamine work? Do they see a psychologist? Do they see a health coach? Do They have to go through a series of sort of, retraining the mind, helping them with neurogenesis. I always say that thoughts are the language of the mind, feeling are the language of the body. What type of pre-work do you expect, these patients to have done before they just take a ketamine drip?
So look, the large majority of people are referred to me by other healthcare providers, very often psychologists and psychiatrists. And so a large majority of the work is being done from their existing support basis. The important thing is that you come into this process, this referral process, with the correct intention. So this isn't a fun process to go through. It's not a club drug or something like that. This is real work that needs to be done. And so you really need to set your intentions for what you want to get out of this properly, and you need to integrate the actual process itself after the series with the correct people. And if you're not prepared to do the intention setting properly beforehand and to integrate what you've learned from the process afterwards, you might find yourself regressing and going back to where you started. So the process, people would come to see me. I see all my referrals for an hour beforehand. We take a proper full history from them, a medical history, a psychiatric history, mental health history, a drug history, for example. And I go through all of the blood results that they've had done before to make 100% certain that there's no underlying contributing factors such as an iron deficiency, hypo or hyperthyroidism, vitamin B12 deficiency, that there's no underlying liver or kidney problems, for example. So we look at the physical aspect of them, we examine them properly, make 100% sure that they're safe for these infusions. We exclude people that wouldn't be safe for the infusions. For example, people with uncontrolled, unstable cardiovascular disease or angina, for example. You could imagine that pushing their blood pressure and their heart rate up a little bit might be taxing for the heart. So we do the ECGs if it's necessary. We exclude that they don't have a background history of psychoses, psychotic disorders, schizophrenia, substance-induced psychosis, although in the right hands, people can get away with this if they've been monitored closely by a psychiatrist. But we're very cautious with those patients. Patients that are bipolar, with a history of mania, for example, we exclude that. So the pre-work from my side is always to examine people properly and make sure that they get the informed consent, that they understand the process, that they understand the risks and the benefits to this process, that they understand that it's not a silver bullet. And then with their consent, we go ahead with the process. We normally do somewhere between 3 and 6 infusions. Most of the evidence is for 6 infusions, 2 a week for 3 weeks, or 1 a week for 6 weeks. So they go home, they take a look at all the information, they discuss it with their family members, with their psychologist, with their psychiatrist, they do their intention setting, and then they actually come to the rooms on the day for the actual process. It's a 90-minute process from the moment they walk in to the moment they're done, and in a very safe environment, one-on-one. Every patient has a doctor watching over them for the entire duration of the infusion. It's a very personalized process. We put the drips up for them. We control the dosing of the medication, and we individualize the dosing according to the patient's history, according to the medications that they've used previously, according to the substances that they've used previously. So we tailor the dosing specifically for that patient. We put a drip up for them, an eye mask. We put very relaxing meditation type deep sleep music on for them, and we control the process with blood pressure monitoring, oxygen saturation. We administer supplemental oxygen, very rarely required, but if it's needed, we administer supplemental oxygen. We remove the drip from them 45 minutes to an hour later, and we allow them to recover as long as they need. We make sure that they're not nauseous, that their vitals are all stable, and then they can go home.
Sure. And what about breath work, or having someone alongside them, or a family member, or therapist or hypnotherapist to be there with them, someone that can help them feel safe or secure? Can that be part of the process?
Absolutely. Every single patient is given the opportunity to bring a chauffeur along with them. And most people take us up on that offer. Firstly, because they can't drive themselves home, so they need someone to come and sit there with them. And secondly, because it's quite a vulnerable process, and so they feel very safe to have their significant other sitting in with them. A lot of the psychologists that refer patients to me come along for the infusions as well. They sit there for the duration of the infusion. most often they do not talk to the patients during the infusion, although if the patient wants to discuss anything during the actual process, they're there to interact and engage with them. And I fill that role when there isn't a psychologist or hypnotherapist or psychiatrist that's coming along for the infusion. It's mostly psychologists that would sit with their patients, and they're sort of engaging in a ketamine-assisted psychotherapy type of model. I'm not trained in doing that. My background is in anesthesia, so I'm actually making sure that the process is run safely. But if I see any form of anxiety or stress come up from the actual process itself, I'm very good at containing that and bringing people back, and I watch their heart rates come down just to ensure them that they're safe, that they're completely fine, that there's no issues with their vitals, and that normally settles them down and they do really well after that.
Brilliant. Tell us about the research, and people are going to want to know about the evidence and the research. How long has it been done for, from a research, double-blind, randomized controlled trials? What is out there with regards to evidence that people can go and have a look at?
So look, I think there's a lot of evidence that's come out for it. The large majority of the evidence is for treatment-resistant depression and for suicidal ideation. And so ketamine has been shown to almost overnight reduce suicidal ideation, not in everyone, but in a substantial portion of people that are suicidal. So the biggest benefit will be found for treatment-resistant depression and for suicidal ideation, very much guided by a psychiatrist, because of course you have to understand that these patients should usually be admitted to a hospital under the guidance of a psychiatrist. So very often the psychiatrist will say, look, we've tried everything and we're moving to ketamine now for the patient. So the evidence started from the year 2000. I think the Yale investigators there were actually investigating ketamine for mental health conditions. And so as time's gone on, the evidence has really come out for treatment-resistant depression and for other anxiety disorders and substance abuse disorders to show that there's a significant benefit. Look, unfortunately, just like any form of antidepressant, there can be a huge proportion of people that undergo ketamine that will regress, and that's why I say that the integration component to this is extremely important, that this is a tool in the toolkit and not just a one-hit wonder. Of course, there's conflicting evidence now between electroconvulsive therapy versus ketamine infusion therapy. There's transcranial magnetic stimulation that's coming out now. So I think people are realizing that Western medicine, in terms of the antidepressants, antipsychotics in the treatment of these mental health conditions, in a substantial portion of patients, somewhere around 30%, Western medicine just doesn't have the answers, and so we need to look at alternative approaches for people, such as ketamine infusion therapy. Look, electroconvulsive therapy definitely plays a role. There is a huge side effect profile to that, but it has been shown to be effective for treatment-resistant depression. So, and then more recently, there's obviously been a huge upsurge in an interest in psychedelic medicines, such as psilocybin. For example, a trial came out in November last year for treatment-resistant depression through the New England Journal of Medicine. I think it was reported, Robin Carhart Harris. And so I think we're looking at a time now, a really interesting time, and I think all the evidence and randomized controlled trials will come for ketamine, for psilocybin, but obviously that is not considered legal yet, and so it cannot be prescribed in South Africa.
Cool. Tell us a little bit more about how important it is for patients out there to have a look at functional medicine markers like vitamin D, that is so important and crucial for mental health and well-being. Things like iron and ferritin seems to be an absolute epidemic of, on both poles, way too high ferritin that's causing a lot of oxidative stress, and then way too low that's causing significant problems. So how important it is patients actually look at these markers and get someone to manage them and measure them?
I think every single person should have someone doing that for them, which is why when I see them for the initial consultation, I go through and see what results have been done for them. The iron is extremely important. So obviously a low iron is a massive contributing factor to mental health conditions such as depression, and women in particular affected by having periods with a low iron. And obviously diets these days are really not fantastic, and so from a low iron, extremely important, but a high iron, conditions such as hemochromatosis, which is really more common than people think. I think it's about 1 in 10 Caucasian patients that have got a heterozygous hemochromatosis, which still has an iron overload potential to it. That's just a genetic disorder. And then you've got chronic alcohol use, which can cause a high ferritin, which also causes oxidative stress. So you should be looking at a CRP, or ideally a high sensitive CRP, to look at the patient's inflammatory state and try and correct their inflammatory conditions. If they've got a high ferritin, you need to look whether that's inflammatory in nature, whether it's hemochromatosis in nature, whether they're just consuming too much iron, for example, or taking too much vitamin C. They say, look, vitamin C is good for you. Yes, of course, but if you're taking too much vitamin C, it can cause absorption of iron if you've got something like hemochromatosis. So we look at sugar, we look at insulin, we look at vitamin D, we look at calcium levels, we look at magnesium levels. We should be supplementing vitamin D, which, since COVID, I've been testing vitamin D routinely, and it's scary how many people are vitamin D deficient. Levels of 6 and 10, and so hugely important. And I don't think that the ketamine is the be all and end all here. I think that we should take a step back and be looking at the people's functional status, and from an integrative approach say, look, we need to be looking at mind, body and soul here, and trying to tweak all of those things at the same time to get clinical benefit.
Brilliant. The risks, what are the downsides? Have there been a lot of side effects from people coming in and being worse off? Or obviously something that's got great reward can have great risks. So what is your sort of experience with people who've had ketamines, like 1 or 2 or 6, have a great reaction, and all of a sudden they're far worse off than they started? Is that a possibility?
Absolutely. Any antidepressant, in fact, there's black box warnings for the serotonin reuptake inhibitors, for example, that in the first few weeks of treatment, it can worsen your anxiety or your depression. It can, especially in adolescents, it can worsen their suicidal ideation. So any antidepressant therapy, you need to be monitored quite closely. The side effect profile is all usually within the first 48 hours. The most common side effects are nausea, fatigue, and a headache, which the large majority of people complain about. It's almost like a terrible hangover, unfortunately, and we can't really mitigate those risks. It's just a side effect profile of taking ketamine in general. Short-term memory problems are usually an issue with ketamine, and the way I describe it to patients, it's almost like someone's just taking your operating system and shutting it down, defragmenting it and rebooting it back up again. Usually after 7 days, their memory jacks back up again, but the complaint of having short-term memory issues is obviously very real. I think the risk of addiction, of course, it's like any substance. If you don't have the correct respect for the substance, you can develop a tolerance and you can develop an addictive potential to it. In the experience that I've had, I don't have any patients that are addicted to ketamine, at least not that I know of. I don't have people coming for regular enough infusions in my sort of facility where I'd be allowing them to develop an addiction to ketamine itself. But of course, you have to be careful in people with a history of substance use, because you can develop interstitial cystitis, bladder issues with long-term ketamine use. There can be cognitive impairment in using too much ketamine, and so you have to really have a respect for this.
It seems that it's going to be far better because you're setting up a drip that's about an hour long, maybe it's 6 hours of a drip, compared to someone taking an antidepressant. And I'm not anti-antidepressants, they have their role in their use, but it just seems that a lot of people that do not benefit long term from antidepressants, and then they don't go through the correct weaning or withdrawal program with those drugs, and that causes significant issues, and often another drug has to be added. But it seems like it would be far more non-addictive than a Western drug. You're taking a dose every single day for months versus 6 doses, over 3 weeks or 6 weeks. What do you think about that?
Look, I mean, it depends on who you ask. I mean, if you're going to ask me, and I mean, I've been through the process myself for mental health reasons, and so I understand, having used the substances myself, the numb feeling that I felt personally from taking SSRI and SNRI medication. It did numb down, and it helped alleviate some of the depression and the anxiety, but I got to a point where I felt like all I was doing was ticking the boxes to get to the next day. And so I actually went through a series of infusions myself, and I can say that I wish that I had tried that first before, but that's personalized to my situation. There are a lot of people that take antidepressants that achieve remission, they have no problems taking it for the rest of their lives and no long-term consequences. And of course, that decision needs to be made with the psychologist and with the psychiatrist that's treating those patients. There are many people that get referred to me that are absolutely anti-taking any form of serotonin, noradrenaline, dopamine medication, that want to try something that can potentially resolve their post-traumatic stress disorder, their anxiety, their depression, without having to commit to the long-term side effects of these medications. And of course, they've got horrendous side effects in a large majority of people. For example, weight gain changes, sexual dysfunction, anorgasmia, that numb feeling. So there's a lot of people that have residual symptoms from taking one antidepressant, and that they then get prescribed a higher dose, which then causes them more side effects, and then the psychiatrist or their general practitioner will then switch their class of medication, and then we've got the second set of side effects that come. Very often antipsychotics get thrown into the mix and other adjuncts to help patients sleep, for example. So the worst drug for me is chronic high-dose benzodiazepine use that causes huge neurological issues for people taking. And they very often think, well, I just need to stop this medication, but they actually need to really gradually taper down these medications and not just stop them, and should really discuss this with their psychiatrist. And they think that they can just stop their benzodiazepine overnight, and you see the withdrawal from that, and that's terrible. So these drugs, they have a place, they have a use, but they should be used really with respect, and in my opinion, with the benzodiazepines, for the shortest duration of time for the least number of patients.
So you went from pain to purpose, you went through the process. Would you be open to sharing sort of your own story, what happened and how you actually got into ketamine? Was it through your own journey?
Yeah, sure. So my general practitioner, he'd been treating me for depression and anxiety for many years, and in 2018, 2017, somewhere around there, we had a patient with chronic regional pain syndrome after an operation to their wrist. And so I was researching alternative treatments for chronic regional pain, because we'd tried all the conventional treatments, and I stumbled across ketamine, obviously with the ketamine for chronic regional pain syndrome and other pain conditions such as fibromyalgia, for example. And so we actually utilized ketamine for this patient, and noticed a positive response there, and then started seeing all the evidence for mental health conditions. And I thought, well, you know what, I've really struggled with depression and anxiety myself for many years. I'm going to give it a try myself. And so I've had 4 ketamine infusions. Really, I really respect the process. I still see a psychiatrist regularly. I still see a psychologist regularly. So I do all of the hard work. I've seen a hypnotherapist, Thomas Budge, who's been really amazing for me. I watch my blood results quite closely, and so I've done all the hard work, the preparation work for this. But the actual ketamine infusion itself was one of the most profound experiences I ever had in my life. I mean, I felt a ego dissolution. I felt a oneness with everything that came before me, everything that came after me. I felt like I was a speck out there in the universe, and I came back with an altered state of cognition, with my anxiety and my depression substantially improved. And so I'm not saying that there haven't been bad times since then. For example, I went through a few episodes of burnout, especially during COVID, trying to manage that sort of fear response that was created there. So it's been a work in progress for me, but it's been a substantially beneficial tool for myself personally.
Now, do you think the ketamine is related to unlocking trauma, childhood trauma, or neurogenesis that didn't really process well when you were an adolescent or teenager, or issues with sex hormones? Do you think there's a unrooting of trauma and issues and pain growing up that was sort of healed or unlocked or rerouted, as you've said, or neural pathways that have come into being that are far better and far better for mental health in your case?
So, look, I really am a firm believer in transgenerational trauma, in epigenetics. Those studies that came out with mice where they would shock the mice while they were smelling a cherry blossom sort of scented smell, and 2 generations down the line, those mice's grandchildren, never having been shocked before, if they smelled cherry blossom, would run out the cage. And you just think of what our species has been through in the last 150 years with 2 world wars and 50 million people killed in World War II, for example. And both my grandparents were in World War II, and I don't know how much of the post-traumatic stress disorder and alcoholism was passed down through to me from my grandparents. And then you've got the trauma of your intrauterine, your birth trauma, your traumas of early childhood, so I think there's a lot that gets stored in your cellular memory. And I think...
Did you say you're a medical doctor?
Yes.
Most people would be thinking now, if they're a health practitioner, Dr. Sean, and saying, listen, is this transgenerational trauma? Is there research to this with humans? Is this, is there science to this? I mean, I'm a huge believer and I agree with you, but it's just fascinating. It's inspiring, and it brings me hope that someone with a very strong scientific medical doctor approach will look at this and say, this is possible.
I don't think it's possible. I think it plays a major role in psychopathology. I think that we're looking at traumas here. We're looking at, but there's a huge subset of people that say, nothing's ever happened to me. There's a huge subset of people that have said, I've got wonderful parents, I've got a wonderful upbringing, I've got wonderful siblings. I don't recall ever being abused physically, mentally, emotionally, sexually. But I'm still depressed and I'm still anxious. Well, how far back does this go? Is it my grandparents? Is it my parents? Is it my great-great-parents? I'm not sure. Maybe it's got nothing to do with it. Maybe it's traumas that I've repressed from the age of 2, for example. But the thing about ketamine, and I think the psychedelics in general, seem to unravel this process. But I think they really go down inside Pandora's box, and they help shake things up a little bit, and in the right hands and with the right support system, I think they help you rewire and restructure and reorganize your trauma. I don't think you're ever going to forget it. If you've been through an Iraq war, an Afghanistan war, I don't think you're ever going to forget the trauma that you've seen. But I think that there's an opportunity for you to rewire your mind so that the emotion that's associated with that trauma doesn't plague you and haunt you.
Sure, fascinating. So why should someone rather do ketamine versus psychedelics?
Look, I think the legality is obviously a big problem, and I think that the problem with psychedelics is that they're being used in the wrong hands, and they're being used for the wrong people, and they're being used in people that are still taking serotonin medications, for example. So people are not being guided by the right people. I think in the right hands and under the right facilitators, and there are those type of people even in South Africa that can guide people in the right way to take psychedelics. And there are places in the world where it's legal. For example, in Jamaica, you can go and you can do these sort of processes legally. I think as time goes on and as the legality side, Johns Hopkins, for example, are taking people with chronic depression with cancer diagnoses, and they're legally administering these magic mushrooms or psilocybin to these people, and the good evidence is there for them. But there's a huge screening process that I think is not done, and I think a lot of people are seeing this evidence and they're applying it in an unstructured format. And I think that's where the concern comes in. I think if you have somebody with experience in psychedelics, with experience in oral medications, with experience in weaning off, fine, sure. There's also a huge subset of people that say, you know what, I have the right to explore my own consciousness the way I want to, and if I don't want to take Western medication, I should have the right to take something that grows out the ground in terms of improving my mental health. There are a lot of people that say, well, you know what, I don't have psychopathology, I still have the right to explore other realms of consciousness. And I agree with that. I think that people should have the right to decide on whether they change their cognition and their consciousness through alcohol, for example, through marijuana, through, done in the correct way. If that's what their decision is, they should be allowed that opportunity, but they should be guided properly. Who shouldn't be taking marijuana? Who shouldn't be taking psilocybin? Who shouldn't be taking ketamine? I think the problem comes in is where you get it from your friends, or where you get it from the incorrect sources, where it's not done in the correct set and setting, where your mindset is not in the correct place to take these medications, where the actual setting where you have them done is not in a safe environment. I think those sort of things need to be adhered to.
So going to a party and then your friends got shrooms and it's a shroom party, and then some guys say, listen, it's quality, just don't drink alcohol, but it's going to be a cool time, so take these shrooms. Would you recommend that?
I find alcohol is the world's worst drug. I think, and I was driving here to your offices today, and at Clay Oven there's a giant, I don't want to say the name of the company, there's a giant whiskey brand that's advertising over there. Here you've got, if you look at a Delphic analysis, so I think Professor David Nutt did a graph on substances that cause personal harm and substances that cause societal harm, and I think alcohol is far at the top there. And heroin and cocaine and the opioids and those sort of things come down there. I think things like ketamine are much lower down the list, psilocybin much lower down the list in terms of individual harm and in terms of societal harm. So I think that a time will come where people will be turning more towards other substances that alter their consciousness. Maybe that would be psilocybin at a party, as opposed to getting drunk with their friends and crashing their cars and the aggression that's caused, the anger that's caused by drinking too much alcohol. I just think that it's a societal norm at the moment to get drunk, to drink, and the harm that gets passed on to society far supersedes that of the risk of psilocybin, in my opinion. But again, it's not legal and it needs to be done in the correct framework.
Yeah, valid point. If we want to look at drugs and look at alcohol and what it's done, possibly big alcohol, big food have benefited significantly financially from legalizing, in inverted commas, these drugs that actually have caused significant damage. So why shouldn't psilocybin and things like psychedelics be available to people to use under the correct circumstances? And maybe there'll be an age restriction. You can only buy it if you're 18, under parental guidance or whatever the story is. But I think that's a very valid point. Okay, tell us about the future of ketamines, where you see it going. Is it progressing? Are you learning every year? Like, I've been in practice 24 years ago, and to what I did 20 years ago, I look back and I say, geez, it was okay, but flip, I've learned a hell of a lot and I've grown. And some of my patients in the first 5-10 years were more like, we were trying things, and obviously you want to be safe and you want to do anything to harm people, but you've just learned a lot. Is that the case with ketamines? Are we in the infancy, or do you think in like 2-3 years time you're going to say, hang on, in 2023 I had a good grasp of what I was doing? Give me your thoughts there.
Look, I think you have to remain humble. You have to say, science changes, society changes. My hope is that we don't have to administer the amount of ketamine that we're administering, that society will go back to their roots, and they'll look at better parenting for their children, at dealing with their transgenerational traumas, at dealing with their alcohol use disorders, at dealing with their addictions, and actually do the hard work, as opposed to taking the easy way out of seeing a psychiatrist, taking a pill, not getting better, taking ketamine. I hope that I look back in 25 years' time and say, I'm so glad that I don't do as much ketamine as I do now. I've done over 1,000 infusions in 3 years at my facility. So there's definitely a use for it. I'm hoping that they can develop a substance that doesn't have the same out-of-body experience, the hallucinogenic potential. I'm hoping that they can create an NMDA glutamate receptor blocker that doesn't have the same side effects as ketamine. I'm hoping that psychotherapy advances, that psychiatry advances, that we really do the hard work to try and prevent mental health and treat mental health a little bit more integrative, and I just hope that we can heal as a society and we can heal this planet.
Sure, and I think that's inspiring and hopeful. I see ketamine just exponentially increasing, hopefully because antidepressants and drug use on a daily basis is so prolific, and I don't think is managed correct from the patient side and the practitioner side. People have been on it for years, and I just don't think there's a place to be enslaved, whether it's a supplement, whether it's a drug, whatever it is, whether it's ketamine, that you're enslaved to this process. And that's what I like about the psilocybin and I like about the ketamine. It's a course, it's to help you but then you need to do the lifestyle factors and the healing and the community and the purpose, and doing that type of work to, you know, maintain your gains or sustain your transformation. But this ongoing taking of a drug, whether it's alcohol, whether it's marijuana, whether it's a TCA, whether it's SSRI, I just don't think that's going to really be helpful to the human race. And I think we need to cut enslavement and rather put things in place that can help you along your journey.
Yeah, 100%. I mean, if we talk about psilocybin here, just out of interest, I mean, we have experience with Western medicine drugs for a little over 100 years. I mean, penicillin, early 1900s. So we have a very limited experience as to what these drugs are actually doing long-term for people. Guys in Peru and the Amazon have been using these mushrooms, medicinal mushrooms, for many thousands of years. I think they would have picked the ones that caused harm and they would have stopped using them. They wouldn't have continued using psilocybin mushrooms if they didn't think that there was some form of benefit to using them, and things like ayahuasca and that sort of stuff. I think the clinical evidence, the science, the Western medicine, randomized, double-blind, placebo-controlled studies will come out, because that's what people want to see. They want to see reputable sources. I think it's difficult because you can't isolate the shamanic approach to treating people, the holding space for people. You can't randomize that into a clinical trial. You want to give someone a placebo versus the mushrooms, I can tell you they'll know exactly what they got. So it's not so easy sometimes, and sometimes the anecdotal evidence supersedes that of the randomized trial, and I think it's going to be difficult, and hopefully it comes out in a safe way, and hopefully it doesn't cause any issues. It's still in the infancy of using this globally.
Okay, so future of ketamines in South Africa and beyond, is it going to be upgraded? Is it going to be changed, do you think? Where do you see it going?
Look, there are hundreds of ketamine clinics that have opened up in the States. There are limited facilities in South Africa that are administering ketamine safely under the guidance of healthcare practitioners. The ketamine clinics of South Africa, for example, they've got a few branches, and I'm very good friends with Alan Howard, who's pioneered that in South Africa, and I think their facility does quite good work there. And I think as long as people's intentions are pure here, as long as it's really to try and help people, I think that we've just got to be careful that this doesn't just become a one-stop shop, that people are not just getting sent through ketamine for the sake of getting sent through ketamine, that they're guided to do all the hard work that we've spoken about today with people like yourself, for example. You know, we've spoken about your Made to Thrive, and I love the term thrive, but thrive is a mind, body, soul.
Yes.
Thrive is very much a preventative, prophylactic approach, and that we should try to be catching people in their infancy rather than just sending them through a ketamine infusion. And I think that we need to just take a step back and say, has that groundwork been done with people like yourself before we just go and administer ketamine?
Good. My one concern, I want to talk about children, adolescents, when you can start ketamines and what age you can go to, is that over the years I've seen the elderly who've struggled with cognitive decline have an anesthetic, you know, do a hip replacement, do a knee replacement, they're under anesthesia for a long time, they come out and the family says to me, my goodness, the cognitive decline has absolutely deteriorated. My mother, my father's not the same, they've got a great hip but they cannot do anything from a mental performance aspect. Well, what are your comments with regards to anesthesia and the possible mental decline and cognitive decline that we're seeing rapidly in the older age group?
Yeah, massive. And I think that the vascular component to that, the inflammatory component to that is huge. I think the Alzheimer's disease and amyloid depositions and that, they very much have a inflammatory component towards that. And so look, I'm not really using ketamine for the elderly, although there is some evidence that's coming out from places overseas that there is a use for ketamine in terms of the brain-derived neurotrophic factor, that you might see a positive cognition effect to this because of the low dosing that we're using, as opposed to using the anesthetic gases, the vapors, the other intravenous drugs that we use for anesthesia, that a low dose of ketamine might assist with brain-derived neurotrophic factor in terms of improving cognition. I think the studies aren't quite there yet for it. I think the mental health conditions, treatment-resistant depression, anxiety, post-traumatic stress disorder will definitely take a front seat here in terms of the infusions, but we might see a spillover effect for people with those conditions as well as cognitive impairment, where we either see a rapid decline in their cognition or we see an improvement in their cognition from the ketamine per se.
Okay, good. A 13-year-old with anxiety or depression, a 9-year-old, when can people start using ketamine infusions? What age?
Look, that's a very difficult question. I think the ethics behind that are quite substantial. And so the patients that, I mean, I have got experience in administering these infusions to children and to adolescents, but it's very much guided by their psychiatrist. Just because I really think that there will be a place for it in the future, but I think that people are very hesitant in the younger population in terms of consent for it and in terms of the possibility of causing fear in those minds. Those minds are certainly not set yet, and I think until they're in their 20s or their 30s, they still don't quite fully understand the process, and it's quite a profound process to go through. Having said that, the patients that I have administered ketamine to that are under the age of 18 have had positive response to the infusions, and so we hold space for them very cautiously. We make 100% certain that there's really good follow-up care by the person that's referred them to us for treatment-resistant depression and for suicidal ideation, because we're seeing a lot of younger children really struggling mentally at the moment.
But what about anxiety? I mean, you're dusting the snow like early, you're not allowing it to settle, you're wiping the slate clean. I mean, the longer you allow that trauma, as long as you allow that neural pathway to be used again and again, the harder it is to break that and set something new. So you would think that if someone went through trauma, if they've got significant anxiety, give them an option on not putting on them on a drug. And I'm emphasizing this point continually every single day. That's going to have a systemic like effect like no other on the nervous system. Rather give them an opportunity, maybe a low dose ketamine, to help them wipe that slate clean and really, cause neurogenesis at another level without continual drug use.
Look, I think that makes a lot of sense, Steve, but you can understand that we're guided here by a pharmaceutical dominant industry, and we're guided by guidelines, we're guided by DSM-4 criteria and 5 criteria. My opinion is that I believe that that's a better approach to do something that's potentially 3 to 6 weeks that can unravel and unwind cellular trauma and post-traumatic stress disorder from a severe trauma that's happened to a young child.
Yeah.
That makes sense to me, as opposed to sending them and committing them through to long-term high-dose medication.
Yeah.
But that's not what the textbooks want us to say, and that's not what you're going to have medical legal people jumping in here going, oh, here's this he's not a psychiatrist, here he's administering ketamine to younger people, which is why I say, I think, my opinion, my genuine belief is that if that was me as a 13-year-old, I'd wish I'd gone through that process earlier and not have to go through the trauma of being through the number of antidepressants that I've been on, the brain zaps that I've experienced, the weight gain changes that have happened to me from taking these medications. That's my personal opinion here. I'm just, obviously it's a medico-legal environment.
Sure.
Everyone's sitting in here. So
what's happening in the States then with a 13-year-old that's gone through trauma? Is that legal that they can have ketamine?
I think it's legal. It's obviously off-label.
Okay,
So
sure.
ketamine for treatment-resistant depression, whether it's a 13-year-old or a 21-year-old, you have to say, look, well, the risks of this person committing suicide are substantial. We've tried the other therapies for them. Let's try ketamine. Of course, it's an option for people.
Okay. And in South Africa, are psychiatrists doing ketamine, or do they say, okay, I've got a patient that's 14 years old, got post-traumatic stress disorder, really struggling, and we're not winning here, then do ketamine? Is that legal?
So there's a psychiatrist, Dr. Rodseth, that's really on board with administering ketamine infusion therapy. There are several other psychiatrists that are more for this sort of approach as opposed to the alternative, which is what we've spoken about with the medications there. I think that the perception needs to shift, and in their minds would need to shift with the evidence, as opposed to trialing something that might potentially frighten someone, for example. So there's a huge reluctance on general practitioners' parts. Look, there's very much an ingrained, entrenched, patients depressed, anxious, give them a SSRI, refer them to a psychologist. We're not doing all the hard work that we're supposed to be doing for them. So to now say, okay, fine, there is some evidence coming out now for the ketamine, you're taking people with a whole 10, 20, 30 years of psychiatric experience and asking them to shift their thought processes to something that's maybe a little bit less invasive in the long term. It's difficult changing people's opinions.
But there's evidence on exercise. I mean, Wendy Suzuki showed the brain-derived neurotropic factor that happens when you do exercise and you do aerobic exercise and you do high intensity. There's really good neuroscience evidence, yet it's not being used by medical practitioners. Why is that?
Absolutely crazy. It's just absolutely crazy. I mean, the diets that we prescribe to people are very much entrenched in the food pyramid, which has been debunked. You know, I mean, the type of stuff that we were taught 30 years ago. Steve, 2,000 years ago, we were telling people for their headaches that we were going to drill holes into their heads. We were giving them trephine, but they would sit in front of their doctor just like they're sitting in front of us, and they convinced them to drill holes into their head.
Yeah.
Maybe in 2,000 years' time, they're going to look back going, oh, Sean Thornley was administering ketamine to people. Oh, my word, like, I can't believe he was doing that. And I'm humbled to say, I believe that this works. But if it doesn't work and if it causes harm, we need to change our approach. And I think the same should be said of the benzodiazepines, the same should be said for the SSRIs, and people need to go back and say, brain-derived neurotrophic factor is inherent in us. We can create that by exercise, we can create that by meditation, we can create that by mindfulness, we can create that through hypnotherapy. I've had some of the most profound things happen to me from doing yoga on absolutely no substances. And so my goal is to be clear of psychotropic medication to try and alter some states of consciousness. However, if I decide that I want to have a glass of wine or I want to have 5 shooters, I want that to be my decision, knowing what the side effects is to that. I want to allow myself that bodily, the word escapes me, but
yeah, that ownership and accountability of your own body, your own mind. Yeah, that's your decision. Okay, what about ketamine's changing numbers? At Made to Thrive, we're using a lot of data points like heart rate variability. We've spoken about it. It's the difference between your sympathetic nervous system and your parasympathetic nervous system. We use devices to show people, because it's really, really helpful for them to use these data points, see these data points. Then they do the breath work, they do the mindfulness, it changes this, you know, the heart rate variability, it improves, they feel much better, they sleep much better. What has ketamine done to heart rate variability? What has it done to cortisol, DHEA or DHEA cortisol ratio, which we look at, which is really, really important? What has it done to any other data points that you know?
So in the initial phases, in the practice that I was working with my general practitioner, Richard Brink, he had a device called a cardioscope, and the cardioscope is even utilized by cardiologists in South Africa now. German military technology here that very accurately measures heart rate variability changes, and so the increased heart rate variability obviously better for your system, the decrease in heart rate variability obviously poorer for your system. And so in the initial phases of administering ketamine, we would place this cardioscope monitor and we would track them as if they were sleeping, and we would see the dosing that we would use to get them into a REM sleep phase of the sleep cycle, which obviously is based on heart rate variability, breathing, etc. So we watched their heart rate variability, and that system gave us a sympathetic versus parasympathetic outcome, and we could show patients objectively improvements in their heart rate variability, improvements in their stress levels, etc. So in an ideal world, we would monitor baseline cortisol levels. Absolutely, DHEA cortisol ratios, for example, would be hugely beneficial. We'd watch high sensitive CRP to see whether or not there was an anti-inflammatory approach, because the inflammatory nature of mental health conditions is definitely a hot topic, and that depression might have an inflammatory nature. Of course, if you watch something like a high sensitive CRP, great. We're just unfortunately limited by finances here. They're not just paying for the infusions, they're paying for integration, they're paying for their psychiatrist. So in an ideal world, we would track that, and it would be a great study to do.
What about medical aid and medical insurance reimbursements? Can people get and claim from their medical aids?
So look, Alan Howard's working quite, I had a meeting with him recently from the Ketamine Clinics of South Africa, and they're meeting quite closely with the funders to try and show them that as opposed to long-term therapy, you've got an opportunity here. Yes, it's a bit labor intensive and cost intensive in the initial phases, but over a 10, 15, 20-year period, you're substantially saving money for people. So the funders now are funding these things through the savings. The infusions vary from anywhere between 1,500 Rand to 3,500 Rand, depending on the facility that administers these infusions. And hopefully the funders will come on board here. It'll need to be referred by psychiatrists, obviously, so it'll be psychiatrist referral based, and general practitioners wouldn't have that gate key to this. So the psychiatrist will say, look, this patient ticks treatment resistant depression or suicidal ideation, as opposed to admitting them for a few weeks, which has got a huge cost associated with it. Let's try the outpatient ketamine, and hopefully the funders will come on board with that.
Brilliant. We're coming to the end of the show. Possibly give a message of hope with regards to mental ill health, and I've seen it just absolutely deteriorate. The young, the old, the middle age. People are just coming in saying, I'm emotionally tired, I'm burnt out. Never in my career have I needed to go and do so much debriefing and speak to people, because I'm just seeing so many patients that are really struggling, whether it's a chronic disease like cancer or heart condition, but mental ill health and just burnout and just having no emotional reserve. Now, talking my practice, people are coming here and emotionally vomiting. They come here and they just offload because they just can't cope. So possibly a message of hope with regards to mental health. It seems like it's just going in the wrong direction. It is. I mean, I speak to my colleagues, I speak to a lot of people, and people are just, getting sicker earlier, younger. I think of my own daughter who's 6, who went through the pandemic saying, Dad, I'm scared of the virus, and where's the virus, and what's going to happen, and why are we not going to school, and why can't we go here, and why is everyone wearing masks? And I just think of my own situation, and thank God she's being able to process that, and she's in a good space. But tell us about just the future and a message of hope for people.
Look, I mean, what I tell my patients that come through to see me is that if you think about how we lived 50,000 years ago, I think we were doing it right back then. You weren't having to force yourself to exercise. You were naturally doing that just in your daily life. You were getting vitamin D by being out and hunting and gathering and those sort of things. I think we're the only species in the world that eats another animal's milk, and I'm not against people eating dairy, but it's got a lot to say. I think people they're not prepared to do the hard work in terms of diet, exercise, lifestyle changes. They're not prepared to delve back into their transgenerational trauma, go and interview their parents and their grandparents and their aunts and their uncles and say, look, well, where does your trauma come from? Where does my trauma come from? That hard work, I think, needs to be done. And I think people need to man up here and step up to the plate and say, I'm prepared to do the hard work so that I don't have to continue passing this on through to my children and their children. And if they start struggling, I'm going to help them do the hard work as well. And so I think we need to identify mental health problems young. I think we need to address them one way or another at an early age. And I just think, let's go back to basics. Let's just spend quality time with people talking. Let's get off our phones a little bit more. Let's stop this false dopamine high that we get from Instagram and TikTok and Facebook, and let's get our dopamine from exercising and speaking to cool people like yourself.
Cool.
Let's go back.
Well, thanks, Dr. Sean, and just declare favor and blessing over you, that you would thrive, that you would live out the purposes that God's called you to, and thank you for being courageous. I must say it must have been very tough at times to go along this ketamine journey, and it's hard being a pioneer, going, swimming upstream and doing things that people are not comfortable. But I salute you and honor you and respect you, and I hope you just go from strength to strength. And I look forward to many more interviews and look forward to going on your Instagram as well. So thank you.
Well, thank you so much for having me, and thank you for the good work that you do, and the good feedback that I get from people that have come to see you, and to your wonderful wife Helen, and the good work that you guys do. I just really wish you all the best, and let's hope that we on this journey together and that things get better for everyone.
Absolutely, we are. Thank you so much.
Thanks, Steve.